I'm Dr. Jayakumar. I have joined. Yeah.
Good evening, sir.
Good evening. Good evening. Yeah. Hi, Janaki.
Yeah, right.
We have started or?
Hello, good evening.
Good evening, Dr. Varun. Yeah.
Good evening. Good evening, sir. Good evening. നമുക്ക് തുടങ്ങാമോ?
Yeah, we will start, please. We can start. Yeah,
Okay.
definitely.
Hi, everybody.
Hi. Hi. I'm
Uh,
Dr. Jayakumar.
Nice to meet you, sir.
Yes.
എല്ലാവർക്കും വിനീതമായ നമസ്കാരം. A very good evening to one and all. Indian Radiological Imaging Association, IRIA, Association of Malayalam Artists, AMMA, Swasthi Foundation എന്നീ സംഘടനകൾ സംയുക്തമായി ഒക്ടോബർ 1 മുതൽ 30 വരെ സംഘടിപ്പിക്കുന്ന ഒരു മാസം നീണ്ട വെബിനാറിലേക്ക് എല്ലാവർക്കും സ്വാഗതം. പ്രശസ്ത ചലച്ചിത്രതാരം മഞ്ജു വാര്യർ ഉദ്ഘാടനം ചെയ്ത ഈ വെബിനാർ ഇന്ന് 16ാം ദിവസത്തിൽ എത്തി നിൽക്കുന്നു. I would like to warmly welcome everyone to the 16th webinar jointly organized by the IRIA, AMMA and Swasthi Foundation as part of World Breast Cancer Awareness Month from October 1st to 30th. This webinar series is being conducted as the curtain raiser event to the Global Preventive Onco Summit planned by Swasthi Foundation in January 2026. നമുക്കിനി വെബിനാറിലേക്ക് കടക്കാം. നമ്മുടെ ഇന്നത്തെ ചീഫ് അമ്മയുടെ പ്രതിനിധിയാണ് മിസ് എസ്റ്റർ അനിൽ. വയനാട് സ്വദേശിയായ എസ്റ്റർ കുട്ടിയായിരിക്കുമ്പോൾ തന്നെ 2010 നല്ലവൻ എന്ന സിനിമയിൽ അഭിനയിച്ചുകൊണ്ടാണ് മലയാള സിനിമാ രംഗത്ത് പ്രവേശിച്ചത്. പിന്നീട് കോക്ടെയിൽ, ഒരു നാൾ വരും, ഞാനും എന്റെ ഫാമിലിയും തുടങ്ങി വിവിധ മലയാള ചിത്രങ്ങളിലും അഭിനയിച്ചു. 2013 ഇറങ്ങിയ ദൃശ്യം എന്ന ചിത്രത്തിലെ അനു ജോർജ് എന്ന കഥാപാത്രമാണ് ഏറ്റവും വലിയ അംഗീകാരം എസ്റ്ററിന് നേടിക്കൊടുത്തത്. ഇതേ കഥാപാത്രം തമിഴിലും തെലുങ്കിലും റീമേക്കുകളിലും അവതരിപ്പിക്കാനുള്ള അവസരവും എസ്റ്ററിന് ലഭിച്ചു. കൂടാതെ കേരള ഫിലിം ക്രിറ്റിക്സ് അസോസിയേഷൻ അവാർഡും എസ്റ്റർ അനിലിന് ലഭിച്ചിട്ടുണ്ട്. സ്വാഗതം മിസ് എസ്റ്റർ അനിൽ. എസ്റ്റർ, Esther, over to you.
I'm really sorry കേട്ടോ, നെറ്റ് ഇച്ചിരി ബഫർ ചെയ്യുന്നുണ്ടായിരുന്നു. I can't hear you. You're on mute.
You're audible.
Yeah,
Yes.
you can speak now.
Okay. Yes. Hi, everybody. ഞാൻ ഇതിന് തൊട്ടുമുള്ള കോൺവെർസേഷൻ ഒന്നും കേട്ടില്ല, but I'm really happy to be here today and also representing Association of Malayalam Movie Artists, AMMA. So എനിക്ക് സരിയു ചേച്ചി ചെറിയൊരു ബ്രീഫ് ഐഡിയ തന്നിട്ടുണ്ടായിരുന്നു, but I would like to hear more from all of you all. സോറി, ഇത്ര നേരം ഞാൻ പറഞ്ഞത് കേട്ടായിരുന്നോ? സോറി. Okay. So I think this is a great initiative because ഞാൻ ഇങ്ങനെ വീട്ടിലാണെങ്കിലും ഡിസ്കസ് ചെയ്യായിരുന്നു. So my grandmother is a breast cancer survivor actually. അപ്പോൾ അമ്മച്ചിക്ക് ഒത്തിരി വർഷം മുന്നേ, if I'm not wrong, എൻ്റെ അമ്മ 6ാം ക്ലാസ്സിൽ പഠിക്കുമ്പോഴാണ് ബ്രസ്റ്റ് ക്യാൻസർ വന്നത്. അവർ വളരെ നാട്ടിൻപുറത്ത് താമസിച്ച ഒരാളായിരുന്നു. പക്ഷെ ചാച്ചൻ താങ്ക്ഫുള്ളി ആ സമയത്ത് തന്നെ എനിക്ക് തോന്നുന്നു മണിപ്പാൽ പോലെ ഒരു വലിയ ഹോസ്പിറ്റലിലേക്ക് കൊണ്ടുപോകാനും ട്രീറ്റ് ചെയ്യാനും ഇതെന്താണെന്ന് കണ്ടുപിടിക്കാൻ പോയപ്പോൾ അവർ പറഞ്ഞു ബ്രസ്റ്റ് ക്യാൻസർ ആണ്. ഷീ ഹാഡ് ടു റിമൂവ് വൺ ഓഫ് ബ്രസ്റ്റ്. ബട്ട് താങ്ക്ഫുള്ളി അമ്മച്ചി സ്റ്റിൽ ഓക്കെ, ഷീസ് ഡൂയിങ് വെരി വെൽ. സോ ഐ ഫീൽ നമുക്ക് വളരെ ഏർലി ഡിറ്റക്ട് ചെയ്താൽ സേവ് ചെയ്യാൻ പറ്റുന്ന ഒരു ടൈപ്പ് ഓഫ് ക്യാൻസർ ആണെന്ന് ഞാൻ വിശ്വസിക്കുന്നു. അപ്പം ഇറ്റ്സ് എ റിയലി ഗുഡ് ഇനീഷ്യേറ്റീവ്. എല്ലാവർക്കും ആദ്യം തന്നെ സ്ക്രീൻ ചെയ്ത് അത് കണ്ടുപിടിക്കാൻ പറ്റുക എന്നുള്ളത്. സോ ഐ എം ജെന്യുവൻലി വെരി ഹാപ്പി ടു ബി എ പാർട്ട് ഓഫ് ദിസ് ഇനീഷ്യേറ്റീവ്. ഞാനും ഇപ്പൊ ഈ പറഞ്ഞ പോലെ ഒരു ഹിസ്റ്ററി ഉള്ളതുകൊണ്ടും ഐ ഓൾസോ ട്രൈ ടു ഗെറ്റ് മൈ ടെസ്റ്റ് ഡൺ വൺസ് ഇൻ എ വൈൽ. സോ റിയലി ഹാപ്പി ടു ബി ഹിയർ. Thank you.
താങ്ക് യു എസ്റ്റർ. ചെറിയ ഷെഡ്യൂളിൽ നിന്നും നമുക്ക് വേണ്ടി സംസാരിക്കാൻ കണ്ടെത്തിയ സമയത്തിന് വിലയേറിയ വാക്കുകൾക്ക് നന്ദി. നമ്മുടെ ഇന്നത്തെ അടുത്ത ചീഫ് ഗസ്റ്റ് ശ്രീ സാബു ചെറിയാനാണ്. മലയാള സിനിമാ മേഖലയിലെ വളരെ ശ്രദ്ധേയനായ ഒരു നിർമ്മാതാവാണ് ശ്രീ സാബു ചെറിയാൻ. 1990കളിലും 2000ലുമായി നിരവധി ചിത്രങ്ങൾ നിർമ്മിച്ച് അദ്ദേഹം മലയാള സിനിമാ ലോകത്ത് ശ്രദ്ധേയനായി. അദ്ദേഹത്തിന്റെ നിർമ്മാണ ശൈലിക്ക് വാണിജ്യ ഘടകങ്ങളും സാമൂഹിക പ്രസക്തിയും ഒരുമിപ്പിക്കുന്ന പ്രത്യേകതയുണ്ട്. മലയാള സിനിമാ വ്യവസായത്തിലെ സംഘടനാ രംഗത്തും ശ്രീ സാബു ചെറിയാൻ സജീവമായിരുന്നു. അദ്ദേഹം ഒരു ഘട്ടത്തിൽ കേരള സ്റ്റേറ്റ് ഫിലിം ഡെവലപ്മെന്റ് കോർപ്പറേഷൻ ചെയർമാനായും പ്രവർത്തിച്ചു. സിനിമാ നിർമ്മാണ രംഗത്ത് ഗുണമേന്മയുള്ള ചിത്രങ്ങൾ നൽകാൻ ശ്രമിച്ച ശ്രീ സാബു ചെറിയാൻ മലയാള സിനിമയുടെ വളർച്ചയ്ക്കും പ്രൊഫഷണൽ സംഘടനാ രംഗത്തിനും തന്റേതായ സംഭാവനകൾ നൽകി. വി ആർ വെരി ഓണർഡ് ടു ഹാവ് യു ഇൻ ദിസ് പ്രോഗ്രാം. ഒരിക്കൽ കൂടി അദ്ദേഹത്തെ സ്വാഗതം ചെയ്തുകൊണ്ട് അദ്ദേഹത്തിന്റെ വാക്കുകളിലേക്ക് ഓവർ ടു യു സർ. ശ്രീ സാബു ചെറിയാൻ.
സർ മ്യൂട്ടിലാണ്.
ഓക്കെ, ഗുഡ് ഈവനിങ്. ഒന്നാം തീയതി മുതൽ വെബിനാർ ഇങ്ങനെ നടക്കുന്നു, കാണുന്നു. എനിക്ക് ഏറ്റവും ഇഷ്ടമുള്ള കാര്യം എന്ന് വെച്ചാൽ, ഏറ്റവും ഭാഗ്യമായിട്ട് ഞാൻ കരുതുന്നത് സ്വസ്തി ഫൗണ്ടേഷനിൽ വന്നു എന്നുള്ളത് തന്നെയാണ്. കാരണം കുറേ വർഷങ്ങളായിട്ട് ഇത്രയും നല്ല പ്രോഗ്രാംസ്, അത് പ്രത്യേകിച്ച് നമ്മുടെ സെക്രട്ടറി ഒരു കാര്യം ഏറ്റാൽ പിന്നെ നമ്മളെ നിലയ്ക്ക് നിർത്തൂലല്ലോ. നമുക്ക് മനസ്സമാധാനം എന്ന് പറയുന്നത് തരൂല്ലാത്ത ഒരു സെക്രട്ടറിയാണ് നമുക്കുള്ളത്. അതുകൊണ്ടാണ് ഇത് ഇത്രയും ഭംഗിയായിട്ട് നമ്മളുടെ ഈ കാര്യങ്ങളെല്ലാം മുമ്പോട്ട് പോകുന്നത്. വളരെ സന്തോഷമാണ്, കാരണം ഇങ്ങനെ ഒരു കോസിന് വേണ്ടി നമുക്ക് വർക്ക് ചെയ്യാൻ പറ്റുന്നു എന്നുള്ളത് വലിയ കാര്യം. പക്ഷെ ഇപ്പോഴും നമുക്ക് ഈ ഒരു ക്യാൻസർ എന്ന് പറഞ്ഞാൽ നമ്മുടെ ആൾക്കാരുടെ പേടി മാറിയിട്ടില്ല. അത് തന്നെയാണ് എനിക്ക് ഇതിനകത്ത് തോന്നിയിരിക്കുന്ന ഏറ്റവും വലിയൊരു ഘടകമായിട്ട് തോന്നിയിട്ടുള്ളത്. കാരണം ഒന്ന് ടെസ്റ്റ് ചെയ്യാനോ, ഞാനുൾപ്പെടെ ഇതുവരെ ഒരു ടെസ്റ്റും നടത്തിയിട്ടില്ല. കാരണം ടെസ്റ്റ് നടത്താൻ വരെ എല്ലാവർക്കും പേടിയുള്ള ഒരു അസുഖമായിട്ട് ഇപ്പോഴും നിൽക്കുക. പക്ഷെ നമ്മൾ നിരന്തരം സ്വസ്ഥയിലൂടെ ഒത്തിരി ഡോക്ടേഴ്സിനെ, കേരളത്തിലെ ഏറ്റവും പ്രഗത്ഭരായ ഡോക്ടേഴ്സിനെല്ലാം നമ്മൾ പരിചയപ്പെട്ടും വളരെ ക്ലോസ് ആയിട്ടും ഇന്ററാക്ട് ചെയ്യുന്നതായിട്ട് കൂടി നമുക്ക് ടെസ്റ്റ് ചെയ്യാൻ പറ്റില്ലെങ്കിൽ പിന്നെ സാധാരണക്കാരന്റെ അവസ്ഥ എന്താണെന്ന് നമുക്ക് ആലോചിക്കാവുന്നതേ ഉള്ളൂ. ഈ ഡോക്ടേഴ്സ് എല്ലാം പറഞ്ഞിട്ടുണ്ട്, ഇത് ആദ്യം അല്ലെങ്കിൽ ഒരു സെക്കൻഡ് സ്റ്റേജിലൊക്കെ കണ്ട ഈസി ആയിട്ട് മാറ്റാവുന്ന അസുഖങ്ങളാണ്. ഇതിൽ ക്യാൻസറിന്റെ ഭാഗങ്ങളിൽ 90% എന്നും നമുക്കറിയാം. പക്ഷെ അത് ഇപ്പോഴും നമ്മളെ ജനം അത് എടുത്തിട്ടില്ല. എത്രയൊക്കെ അവയർനെസ് ക്യാമ്പയിൻ നമ്മൾ നടത്തിയിട്ട്, സ്വസ്തി മാത്രമല്ല നിരവധി പേര് ഗവൺമെന്റ് ഉൾപ്പെടെ നടത്തിയിട്ടും അതിലേക്ക് ജനം എത്താത്ത എന്താണെന്ന് എനിക്ക് ഇപ്പോഴും മനസ്സിലാവാത്തൊരു കാര്യം. ബാക്കിയുള്ള കാര്യങ്ങളിലെല്ലാം നമ്മൾ ഇപ്പൊ കേരളം മാത്രം എടുത്താൽ തന്നെ ഭയങ്കരമായിട്ട് എല്ലാ കാര്യങ്ങളും പഠിച്ച് കാര്യങ്ങൾ ചെയ്യുന്ന ആൾക്കാരാണ്. പക്ഷെ ഈ ഒരു അസുഖത്തിലേക്ക് നമ്മൾ ഇപ്പോഴും പുറംതിരിഞ്ഞ് നിൽക്കുന്നു എന്നുള്ളതാണ് എനിക്ക് തോന്നിയിട്ടുള്ളത്. എനിക്ക് എത്ര മിനിറ്റ് സംസാരിക്കാം, അങ്ങനെ വല്ലതും ഉണ്ടോ?
ഇല്ല, അങ്ങനെ സമയ റെസ്ട്രിക്ഷൻസ് ഇല്ല.
അല്ല, വേറെ പാനലിസ്റ്റുകളും ഉണ്ടല്ലോ, അത് കാരണം ഞാൻ ചോദിച്ചതാണ്. പക്ഷെ എന്തായാലും ഞാൻ പറഞ്ഞില്ലേ, നമുക്ക് സ്വസ്തിയുടെ ഇത് 31-ാം തീയതി വരെ പോയി. അതിന്റെ ഇത് കഴിയുമ്പോൾ നമ്മൾ പിന്നെ ജനുവരിയിൽ നമ്മളെ ഇന്റർനാഷണൽ ഇത് അവയർനെസ്സും കാര്യങ്ങളുമായിട്ടുള്ള പ്രോഗ്രാം, വലിയ പ്രോഗ്രാം, വളരെ വലിയ പ്രോഗ്രാം വരണം. എനിക്ക് തോന്നുന്ന ഒരു പ്രൈവറ്റ് അല്ലെങ്കിൽ ഒരു ഫൗണ്ടേഷൻ ഇത്രയും ലാർജ് സ്കെയിലിൽ ചെയ്യുന്നത് വേറെ ഫൗണ്ടേഷൻസ് ഒന്നും ഉണ്ടെന്ന് എനിക്ക് തോന്നുന്നില്ല കേരളത്തിൽ. അത് തന്നെയല്ല, നമുക്കിപ്പോൾ ഗവൺമെന്റ് സഹകരിക്കാന്ന് പറഞ്ഞു. ഇപ്പൊ ഫിലിം ചേംബർ ഞാൻ സംസാരിച്ചുകൊണ്ടിരിക്കുന്നു, അമ്മക്കാര് സഹകരിക്കുന്നു. അപ്പൊ വലിയ രീതിയിലുള്ള ഒരു മാറ്റം കൊണ്ടുവരാൻ അല്ലെങ്കിൽ ഒരു അവയർനെസ് കൊണ്ടുവരാൻ സ്വസ്തിക്ക് കഴിയും എന്നുള്ളത് ഉറപ്പായ കാര്യമാണ്. അതിലേക്കുള്ള പ്രവർത്തനം, കാരണം ഇനിയിപ്പോൾ നവംബർ എൻഡ് വരെ ഈ വെബ് കാര്യങ്ങളൊക്കെ പോകുന്നുണ്ട്. പിന്നെ പോയിട്ട് 2 മാസം കൊണ്ട് നമ്മൾ വളരെ വലിയൊരു ഒരു ടാർഗറ്റാണ് നമ്മൾ ഏറ്റെടുത്തിരിക്കുന്നത്. അതിന്റെ പുറകെ ഇനി നമ്മളെല്ലാവരും ഓടി തുടങ്ങേണ്ട സമയം ആയി. ഏകദേശം എല്ലാം സെറ്റാണെങ്കിൽ പോലും ബാക്കി സാമ്പത്തികമായ കാര്യങ്ങൾ ഉൾപ്പെടെയുള്ള നിരവധിയായ കാര്യങ്ങൾ നമുക്ക് ചെയ്യാനുണ്ട്. അതിലേക്ക് പോകാൻ സ്വസ്തിയുടെ കൂടെ എനിക്ക് ഒരു അവസരം കിട്ടിയതിൽ എനിക്ക് വളരെ സന്തോഷമുണ്ട്. കാരണം എനിക്ക് ഇങ്ങനെയുള്ള കാര്യങ്ങൾ പ്രവർത്തിക്കാൻ വളരെ ഇഷ്ടമുള്ള ഒരാളാണ് ഞാൻ. ഞാനിപ്പോൾ ഫിലിം ചേംബറിന്റെ വൈസ് പ്രസിഡന്റ് ആണ്. ഫിലിം ചേംബറിനെ ഇതിനകത്ത് ഉൾപ്പെടുത്താൻ ഞാൻ ഓൾറെഡി ഒന്ന് സംസാരിച്ചിട്ടുണ്ട്. മീറ്റിംഗിൽ വെച്ചൊന്ന് പാസ്സാക്കി എടുക്കാൻ നോക്കുന്നു.
Okay, sir. Thank you. Thank you for your valuable words. നമ്മളുടെ ഇന്നത്തെ വെബിനാർ ടോപ്പിക്കുകളിലേക്ക് കിടക്കാം. നമ്മുടെ ആദ്യത്തെ ടോപ്പിക് ഇമ്മ്യൂണോതെറാപ്പി ആൻഡ് ഫ്യൂച്ചർ ഓഫ് ബ്രസ്റ്റ് ക്യാൻസർ ട്രീറ്റ്മെന്റ്. രണ്ടാമത്തെ ടോപ്പിക് വാട്ട് ഈസ് കോൺട്രാസ്റ്റ് എൻഹാൻസ്ഡ് മാമോഗ്രാഫി. ഈ 2 വിഷയങ്ങളെ കുറിച്ച് സംസാരിക്കാൻ നമ്മളോടൊപ്പം ഉള്ളത് ഡോക്ടർ ജാനകി പി ധർമ്മരാജൻ, സീനിയർ കൺസൾട്ടന്റ് റേഡിയോളജിസ്റ്റ്, ഇൻചാർജ് ബ്രസ്റ്റ് ഇമേജിംഗ്, Lisie അഡ്വാൻസ്ഡ് ബ്രസ്റ്റ് ഇമേജിംഗ് സെന്റർ, Lisie ഹോസ്പിറ്റൽ, കൊച്ചി. ഡോക്ടർ വരുൺ രാജൻ, സീനിയർ കൺസൾട്ടന്റ് മെഡിക്കൽ ഓൺകോളജി, മെഡിക്കൽ ട്രസ്റ്റ് ഹോസ്പിറ്റൽ, കൊച്ചി. ഈ സെഷൻ നമ്മളോടൊപ്പം ഷെയർ ചെയ്യുന്നത് ഡോക്ടർ ജയകുമാർ, പ്രസിഡന്റ്, അസോസിയേഷൻ ഓഫ് റേഡിയേഷൻ ഓങ്കോളജിസ്റ്റ് ഓഫ് ഇന്ത്യ, കേരള സ്റ്റേറ്റ് ചാപ്റ്റർ. Over to you, Dr. Jayakumar.
Can you hear me and see me?
Yes.
Yeah, good evening. First of all, thank you for inviting me for this important session. I'm very happy to associate with Swasthi. And as the previous sessions, this year, this breast cancer awareness month is going very good. And many people are being benefited by that. So before starting this, today, the importance of first topic will be by Dr. Janaki on, because she has to leave early for some urgent meeting. Is it okay if I call Janaki for the first meeting or first session? Is it okay? If it is okay with Varun, yeah, I will invite.
Yes, sir, of course.
Yeah, I will invite Dr. Janaki first. So before that, the importance of this imaging, breast imaging is very important, because the last patient which I saw today at 6 o'clock is a unmarried female, 28-year-old female. She's a professional by IT professional. She came to me with a 2-centimeter lump in the breast. Incidentally, she had some doubt and she did the imaging evaluation and she found out and she came to me. So that was the last patient I saw today at 6 p.m. today. So with that few words, shall I invite Dr. Janaki for her first topic, because she has some urgent family, something I was told. If it is okay with Varun, shall I invite Janaki or I don't know?
Yes, sir, please proceed. No problem.
Yeah. So please, Janaki, join and present your topic on importance of breast imaging, starting from ultrasound, mammogram,
Okay.
MR mammogram, and all those intricacies of your specialty. Yeah.
Okay. Thanks for the warm introduction. And so basically, and it's a very great initiative by IRIA, Kerala AMMA Foundation, as well as Swasthi Foundation and all others. This is probably the first time that such a huge means all specialties are coming under one roof in 1 month, and we are covering almost the entire topic. So we are also not aware of the other specialties. But remember, breast imaging is something where it is a multidisciplinary. So it's not just one person who is treating the breast, it's entire teamwork, and that has to be emphasized. So once a lady is coming, or even rarely males also, you have to tell them that it's not a single person who is treating, it's the entire teamwork which is behind them. So that positive thing has to come right from the beginning. So with that, I'll just shall I share I'm sharing the screen.
Please.
Is it visible?
It's just starting. Yeah, now
Yeah.
it's visible. Yeah.
Put it on. Is it moving? Okay.
Yeah.
So I am attached to Lisie Cancer Center, that is in Lisie Hospital, in charge of the breast imaging. So I'll be speaking today about contrast enhanced mammography, and like Dr. Jayakumar told, we need to know what are the things that are available before going ahead with the advanced thing like contrast enhanced mammography. So I'll be very, it's in a layman kind of, I'm not going into any technical terms. So we know that breast imaging means usually most of the people, they feel, okay, breast can be imaged either with ultrasound or mammography. So this is how an ultrasound picture looks like. This is how a mammography picture looks like, and this is how an MRI breast looks like. So what we are seeing is ultrasound will help us to find out if a lady has got a lump, we can find out if it is solid or fluid containing. Mammography uses X-rays, and it will give us an idea regarding how the breast is, whether the breast has got more tissue, more fat, if there are any masses like what we are seeing here, or if there are some calcifications. MRI is a totally different procedure. It'll give us an idea regarding what exactly the lesion is, and also when we give contrast on MRI, the lesion with the mass that becomes really bright, so it just lights up. So all three are totally different. We do have ladies who come to us saying, a 40-year-old lady, she will come and say, I've got a lump, but I want an ultrasound. No, that is not the thing. Or the 50-year-old lady will come and say, I want screening breast ultrasound. No, that's not the way. So what are the what are the things that we see? Like I already mentioned, on ultrasound, we see that it's a cyst, whether which contains fluid, and we make sure that there is no blood supply. Ultrasound will help us to know if it is a solid mass. So we can see the difference very clearly. So it's a subjective thing done by the radiologist. We hold the probe and we examine the breast side to side. And this is a mass. So what we are seeing here, this is it's a mass, and it has got blood supply. So that means it is growing. Whereas in the cyst, it does not grow. So it is nice. There's no color at all. Some of the advanced ultrasound machines has also got something called elastography. So if you are finding some lesion, it will help us to understand whether it is soft, whether it is hard. So here we are seeing something which is a hard. So it will tell us, it will alert us towards the fact that maybe we are dealing with a malignancy. So advantages in ultrasound are, if a patient has got a lump, it is useful. It will tell us if it is cyst, then we don't do anything. If it is solid, then we have to go in further. It is easily available. Anyone with an ultrasound machine, any ultrasound center, they can do it. But they need to have a small parts probe that is specific for the breast. There is no radiation involved, so it can be used safely during pregnancy as well as during the lactation also. Obviously, cost is lower as compared to the mammography as well as MRI breast. It is very fast procedure. So in India, we have got radiologists who are well trained in ultrasound. So we can just see the lump, okay, what the lump is, we can see and finish off the procedure. And once we are seeing something on ultrasound that looks suspicious, we can go ahead with the guided procedure also. Disadvantages are it is not useful in breast cancer screening. Like I told you, the lady who is past 40 just coming, okay, come and examine my breast with an ultrasound. It's definitely no. It is difficult in large size breast. So one thing that most of the ladies, most of the people don't know is this breast ultrasound up to a depth of 4 centimeters, we can see clearly. But in very large size breast, it's difficult, and there are chances that we might miss out the lesions also. We cannot see calcifications that are seen only on mammography. And like I told, we need high resolution probe for accurate images. So the higher the probe, the cost will also increase. And when we are finding out any lesion, we need to undergo specialized training for ultrasound biopsy. Coming to mammography, so these are the mammography images. So usually when a lady goes to get her mammography done, they take 4 images, 2 for the right, 2 for the left. So along with the compression, they'll be compressing the breast like this, and as well as this way they'll be compressing the breast. They will obtain 2 views. So what do we see? We come to know if the breast has got more of fat or more of gland, because always you have to remember it is in the gland that cancer develops. The more fatty the breast, the chance of cancer development is very less. So this is a fatty breast and this is a dense breast. And these are the calcifications. This will definitely not be seen on ultrasound, will not be seen on MRI also. So this, we know this is a calcification, is a calcium component which looks benign. Whereas here it's got a totally different area and this is suspicious. So based on mammography, we know what we are dealing with. And also the newer versions of mammography has got something called tomosynthesis. We also call it as 3D tomo. So thin sections of the breast is taken, and if you are seeing some mass, we can see the margins very, very clearly. So on mammography, the advantages are it can be used both for screening and diagnostics. Screening means the lady does not have any symptoms. She comes just for examination. The first modality to be used in a lady above age of 40 years is mammography. If a lady even as young as 30 years, she has got a lump, first thing to use is mammography. And like we already seen, the calcification is seen only on mammography. The breast composition can be seen easily. It is a fast procedure. So within 10 minutes, the procedure is done. And additional tomosynthesis shows the margins clearly. Disadvantages are the breast needs to be compressed. So some ladies, very few ladies they're really scared that the breast will be compressed. So ideally, if you are doing a mammography for a lady who has got periods, it should be done within 5. If today is the first day of period, preferable to done it within 2 weeks. They are coming just at the time before the periods, the breast will be very hard and it will be painful for them also. So this is something that each lady has to be aware of when she comes for a checkup. Less easily available, X-ray is used. Some radiation is definitely there. It's best avoided in pregnancy. And it is sometimes, like I told, if there is more of fat, we can make out the cancer clearly. But sometimes when it is a very dense breast, that is a glandular tissue is is more than 50%, it becomes difficult for us to differentiate between the bright glandular tissue as well as the bright cancer. So it will be hidden. This MRI breast, it is just an image to show, representative image. So there is a magnetic bore and the lady will be pushed inside. She has to lie down in prone position. And almost for 30 minutes, she has to be in this position only. Definitely it is claustrophobic, but there are certain indications wherein we have to do an MRI. And this is how clearly we see the images. So both the breasts are seen at the same time. If you are giving contrast, so we are seeing, okay, this is the problem and this is something else. We're able to see things very clearly. But just because a lady is coming and saying, I want an MRI breast for checkup, no, that is not the way. It has to go stepwise. So first we proceed with a mammography, followed by ultrasound. If they still cannot give us an information, then only we have to proceed with an MRI breast. The advantages are it is useful in breast cancer screening, especially the high risk. She has got lots of people in the family who has got breast cancer, or we must have heard about this BRCA mutation. So some genetic mutation is there. So then MRI breast is definitely useful. The breast anatomy is seen clearly in all projections. So we can just reconstruct it. So 3-dimensional picture we'll be getting. The blood supply to the tumor can be assessed. Most of the cancers, they grow because they have got the blood supply. And both breasts can be studied at the same time. Disadvantage, it is expensive. Almost we can say about 5 to 6 times the cost of mammography. And it cannot be used in patients who are claustrophobic. They have to be inside that tube-like structure for almost half an hour. And also the patients who have got kidney impairment with coils and stents, MRI is contraindicated. Definitely takes a longer time. And IV contrast has to be given. And specialized training. So just doing an MRI breast is not enough. The radiologist who is reading the MRI breast should be trained in finding out the abnormalities on ultrasound also. And once we are finding some lesion on MRI, we just cannot leave it like that. The patient has to be referred further. If it's suspicious, then the patient has to be referred to another center where MR biopsy is available. And for us, like in the entire South India, MRI breast biopsy is available only in one center. So what do we need? We need a technique that is fast, it is less expensive. We should be able to see the calcifications and see how much tumor is present. And main thing is just finding the lesion is not enough. We should help the surgeons to plan surgery. And also in high-risk women, we should be able to detect the tumors. So is it possible to have mammography with contrast? And that is how the contrast-enhanced mammography came into picture. The same machine used in mammography is used for contrast-enhanced mammography also with a software upgrade. Here also IV contrast is given. Here the contrast that we give is similar to that of what is given during CT scan. The breast is compressed like mammography, and at the same time the breast is compressed, we get two sets of images. So one looks like mammography and the one looks like slightly different, but it has got an MRI-like information. And the best thing is the cost for the mammography as well as contrast is just 1/4 that of an MRI breast, and CM biopsy facility is available. So where can we use CM? So just to show this, here we are seeing this is a mammography. The lady had come with one mass, which was seen. Mammography is showing additional one more mass. So is that all? Then we went ahead with the contrast enhanced mammography, and we are saying it is 1, 2, and she has got many other smaller cancers also. So it's seen very clearly on contrast enhanced mammography. So if we give this picture to the surgeon, he can plan the surgery accordingly. So either he can conserve the breast or he can take out a larger portion. So it helps in preoperative management for the surgeon. This another lady who came with a lump, but here we are seeing the mass, but it is less bright. The previous one was very bright, means it is got a large blood supply. Here it is less bright. We did a biopsy. This is fibroadenoma. We told the patient, okay, nothing to worry, don't worry. But here on mammography, we are not able to see this mass clearly. So we are not sure if anything else is hidden in the other areas. This another lady, she has got dense breast, what we call. We just don't know if she has got anything. We did a contrast study. The entire thing was bright, but this is been a background type. So she does not have any lesion. She came on a follow-up. She's absolutely fine. So it helps us in dense breast also for screening if there is any abnormality or not. So evaluation of symptomatic breast for staging. Once a cancer is diagnosed, we have to make sure it is on the same, it has got many lesions on the same side. And what about the other breast, opposite side, that also can be checked. Nowadays, patients are given a neoadjuvant chemotherapy. So before there are certain indications in which Dr. Varun will be talking about. So to downsize the tumor. So patient is coming with a large tumor also, it can be downsized. So we have to give the response. So we give the chemo, the size will, so this is also, it's very useful. The patients who already have got breast cancer, so sometimes it becomes difficult. It is post-operative mark or it is because of the radiotherapy or some new lesion has come. It's very, very useful because the problematic area just lights up. And in high-risk patient also. For symptomatic breast, this was a lady who came with she told she had a mass in the left breast. So we are able to see the mass. Okay. So single mass, not much to worry. We did a contrast enhanced mammography. So this is totally different type. So what we are seeing is it's actually eclipse. It's almost like an eclipse kind. So only the background is enhancing. The mass inside is not enhancing. So this means that it is a cyst. So cyst that we saw on ultrasound, this is how it looks like on contrast enhanced mammography. So we are doubly sure, okay, she doesn't have anything. So, but this cyst has got some slight abnormality over here. So actually this turned out, even though it was looking like a cyst, but it turned out to be a very early cancer. We did a biopsy and it turned out to be very early cancer. So helps to plan surgery. So this was another lady. She had some swelling on the left side, but on mammography, we are not able to we know there is something, but we are not able to see the margins clearly. We did a contrast study. It's seen very, very clearly. So we know this bright thing is the contrast, the cancer, and the one inside, we are seeing this slightly darker area. So this means that it is taking up the contrast very fast and the blood is flowing out also. So when we are seeing this, we know exactly, okay, so probably from the bright areas, when we do the biopsy, we have to target that. So it helps us to know the exact size of the lesion. So this was another lady. She came with a swelling in the right breast. We were able to So what happens is we can see some slight calcification. Okay, we know the calcifications are there, but we're not able to know exactly how much is the lesion. So look at the contrast study. She wanted a breast conservation, but here when we saw the entire upper quadrant, like entire upper half of the breast was involved, so the entire thing is cancer. So in this way, even if we go ahead and remove one portion that is the patient was able to see, the chances that the cancer is left behind is very high. So in these cases, we can counsel the patient, okay, so much is involved, so you have to go ahead with a entire breast removal. Coming to the patients who are taking neoadjuvant chemotherapy. So this right breast, this lady had a mass. So we knew it was cancer, and the type of cancer that responds very well to chemotherapy. And this is how it was looking on contrast study. So we know only one mass is there. And what happened was she wanted breast conservation. So this bright thing, what we are seeing. So we put in a clip. So before she started chemotherapy, we put in a clip. And this was taken after chemotherapy. So the entire cancer had disappeared. But we need to go in and take out. So what do we do? So just to show the image, how much is left? So we are saying, okay, then this was the mass before chemotherapy. This is after chemotherapy. So nice, totally the cancer had disappeared. We were able to localize. So with the mammography, we localized this clip. And on the final pathology also, the cancer had totally disappeared. Can be used in problem solving, like I told, when dense breast and when we are seeing multiple lesions, we don't know which to biopsy. This was a lady. She came, she told this is what she felt. Only these two masses she felt, all others were not felt. So we are seeing multiple lesions. We did the contrast mammography. So now we knew, okay, this is something that looks different. So we have to target this one. So really makes our life far easier and it more accurate also. So the thing which is the best thing which is possible is we have got something called contrast enhanced biopsy also. So like I told, in MRI we are able to do, but we are not able to localize the lesion. Whereas in contrast biopsy, this was a lady who had come for checkup. She came with right side, she told she had got some lump. It was a dense breast. We did a contrast mammography. So this is the area that what she was feeling. On contrast mammography, so what she feels, this is something we are seeing. We did a biopsy, this was benign, means non-cancer. But we also picked up something on the left side. So which was not seen in the previous study. In this one, we are not able to see anything on the left at all. On mammography and ultrasound also, we are not able to see. So now what to do? We are able to see under contrast mammography. So this is something called a contrast enhanced mammography guided biopsy. So within 10 minutes, we have to finish the procedure. So we gave we did biopsy. After that, we left a clip also. This turned out to be, the pathologist told us it is benign. So after that, we put her on follow-up, and after 1 year when she came, we are saying that the mass is still there, means even after 1 year, it has not grown in size. So we know it is benign, and the clip is there to localize the area. So it really, contrast enhanced biopsy, the capability is really good. So to conclude, advantages of contrast enhanced mammography is it has got higher sensitivity and specificity, means it picks up the lesions. Also, it is very, very specific in detection of cancers. It is comparable in sensitivity and specificity to breast MRI. So if breast MRI is not available, always CEM can be done. And if it is not seen on CEM, so it means that the chance of cancer is very, very less. And it is not limited by breast density, shorter examination time. The study has to be done within 10 minutes and significantly less expensive than MRI. It allows imaging of both breasts in multiple projections, and we can correlate the areas of enhancement. Like if you are seeing a calcification, that area is showing enhancement, we are 100% sure, okay, this is the abnormal area. And in practice, it is easy to implement than MRI, and no additional space location is needed. Drawbacks are IV has to be given, contrast has to be injected. Since it is iodine contrast, reactions are expected, so we always have to keep the crash cart ready. And there's a small increase in radiation dose than standard digital mammography, but then it is less than the DBT. So, but if it gives us some benefit, definitely that can be used. And there are certain lesions like the ones very close to the chest wall or the ones in the armpit which cannot be seen on CM. For these, MRI cannot be replaced. So with that, I just conclude my talk. So you're muted.
Thank you, Janaki, for taking us through the intricacies of radiology, especially CEM. Just one word on the localization, wire localization, but guided localization. That's also important when you see small lesions like 0.5 millimeter lesions and all that. No, you have to localize for the surgeon or for the oncologist after the neoadjuvant. So one word on localization also, please.
Yeah, so the one case which I showed, so that was having when it had totally disappeared. So we had kept a clip in place. So that was
How you keep the clip?
that is under ultrasound guidance. It was a big mass. So the cheapest way we take out. So if you are able to see under ultrasound, definitely we go ahead with the cheapest way. But when localizing, it had totally disappeared on ultrasound. So we had to localize under mammography. So the best way wherein we are 100% sure, because we cannot just see something, put in a clip and say, okay, you have taken it out. So completely when the mass means, on imaging, we are not able to see any residual disease. We localize under mammography. So either we can target the small calcifications that might be there, or we can target the clip that we already placed. So teamwork, like initially itself, we start off saying, okay, this is what we are going to do. So step by step. So the patient comes for after 2 cycles of chemo, we'll put the clip in, seeing the response. So each time, like we are in constant touch with the patient. So all of us team, it really works well.
Yeah, this for the audience actually.
Yeah.
Thank you so much for taking us through your story. Any questions?
I hope it was not too technical because I just stuck to what the information has to be given to physics. I didn't go into.
I know it's not true. Thank you, Janaki.
Thank you.
So shall I call the next speaker, Dr. Varun?
Yes, sir.
Shall I call him? Yeah. So
Yes.
now that we heard much on the diagnostic part, we have much more on the treatment part. Now we have changed the scenario from chemotherapy, then radical surgery, radical radiation. Now we are targeting the tumor. Many of the breast tumors we can target with your hormone or with your targeted therapies. So that is more useful. It's coming in a big way. So I'm happy to invite Dr. Varun, who will be speaking on targeted therapy and immunotherapy. Immunotherapy is coming in a big way in almost all cancers. So what is the role of immunotherapy in breast cancer? Dr. Varun will be highlighting us, and also he may be talking on targeted therapy. Dr. Varun?
Yes.
Yeah.
Hello, good evening to all, and thank you, sir, for the nice introduction. Thank you, Swasthi Foundation, IRIA, and AMMA for this opportunity. I have prepared a very basic presentation. So just to create a plot for discussion, and as a chairperson, actually, Dr. Jayakumar can lead the further discussion after a basic introduction. So yeah, I will upload my slides. Is it audible?
Yeah.
Is it visible, the slides? Yeah. Okay, so the topic is basically about the future of breast cancer treatment. And so whenever a new treatment comes into the market, actually every person or patient wants to know whether it can be used for my disease or is actually, is it helpful for me? It's a natural curiosity. So I will be mainly presenting on the future of breast cancer. What are the things that we have to wait for, and what is the hope, and also what is the reality? So, so understanding the breast cancer today, we all know it is the most common cancer in women worldwide. But the good thing is that survival rates of breast cancer is improving with early detection, and more people are living longer with the current treatment and better after the diagnosis. This is the basic scenario now. And we all know, actually, over the last 2 weeks, I know actually we all were discussing about the various aspects of early detection. So these are the main tools we are using for early detection, like the mammogram, ultrasound, MRI, and all. And the new tools that is mainly using now is AI-assisted imaging. That is, artificial intelligence is there in medicine also. It can also assist to detect the tumor early and to guide the clinician for designing the treatment. And the other important thing is the role of liquid biopsy. It is still not a standard for the early detection, but definitely in the future it may come up. Usually patients comes to the clinic and they usually ask, doctor, can I diagnose or detect early cancer with a blood test? Usually it is the common question in our clinic. In the future, it may come up. That is called the liquid biopsy. That is mainly with the help of the circulating tumor DNA. So yeah, it may come up in the future as a test to detect the early cancers, apart from this mammo, MRI and all. So the future, the hope is that the simple blood test could detect the cancer at an early stage. So what are the advances in treatment? So as Jayakumar sir pointed out, the targeted therapy is there. That is that drug, the medicine can attack the cancer cells alone precisely, sparing the normal cells. So the side effects will be minimum in this case. The unwanted side effects we can avoid. So at present, we are mainly using targeted therapy in breast cancer, like the antibody treatment using the drugs like trastuzumab or pertuzumab or TDM1. These all are the targeted drugs that we use in the treatment of breast cancer, and it improves the survival of the patient. Then another important thing is immunotherapy. You all might have heard about that. It is actually again an antibody-based treatment. It helps our own body to fight against cancer. Then the third one is hormonal therapy. We all know it is actually an oral pill. No, sometimes if we detect the cancer at an early stage after surgery, we can actually get away with an oral pill alone. It is also a good thing about detecting the cancer at an early stage. Then actually we all now actually living in the era of personalized medicine. So the personalized medicine is that we are actually designing a treatment for each patient. Like a tailor who stitches a shirt for a, that is, it is mainly using various aspects like genetic profile. That is, it is mainly based upon on the concept that each cancer is different. So the treatment for each cancer is also different. So we all have to sit together and we have to discuss about each character of the tumor, and we have to design a treatment for each patient. So that is the all concept of personalized cancer medicine. So nowadays we all are practicing the personalized cancer medicine. In OP and all, actually, as oncologist, we all know the patient will come and ask, sir, actually, you
In between, your sound is breaking.
this actually treatment for that patient. Oh, no, am I not audible?
You are audible, but in between there is a
Oh, is
breaking
it?
of sound.
Okay,
Yeah.
okay, okay.
But you are audible actually. Yes. In between there is
Oh,
break.
okay, all right. So the concept of personalized medicine is that actually, okay, different. So one treatment protocol for a patient is not applicable to another patient. So again, the testing for gene mutations like BRCA, it also helps us to tailor the treatment of a patient. Uh, so that is all about the concept of personalized cancer medicine. So coming to the another important topic, that is immunotherapy. is it applicable in the breast cancer? As I mentioned earlier, it is a strategy to increase the immunity of the patient, and it will attack against the cancer cells. The patient own immune system will attack against the cancer cells. So yeah, our own immune system to fight the breast cancer. Usually the drug used are called the checkpoint inhibitors. That is, we use that in combination with the chemotherapy. So the drugs that we mainly used are called the pembrolizumab or atezolizumab. They are actually becoming a standard of care for early stage and metastatic breast cancer, particularly the triple negative breast cancer. It is not approved for all cancers. It is approved only in triple negative breast cancers. But ongoing trials are exploring their use in other breast cancer types also. Then another interesting topic is the use of cancer vaccines. We all might have read that in newspapers and also in social media that a cancer vaccine has came, and it can be used to treat all cancers. So actually it is still in the infancy stage. So research into cancer vaccines aim to train our own immune system to recognize and to attack specific cancer cells. So this approach has the potential to prevent cancer recurrence or to treat the existing tumors, but it is still in the infancy stage. Only experiments and trials are going on. It is still useful in a clinic. So another advancement is the use of cell therapy, that is mainly CAR T cell. That is, CAR T cell is engineering our own or the patient's own T cells to attack the cancer cells. So it is called the CAR T cells. It is now approved in cancers like leukemia, lymphoma, and also myeloma. But definitely in the future it will come to the solid tumors like the breast cancer and also stomach cancer. So what are the advancements or that came in the field of surgery? That is what all we should wait for, or what? What's the hope in the field of surgical aspect? The most important one is avoiding surgery. That is it possible to avoid surgery in a case of breast cancer? Yes, it is possible, but only in selected cases. That is, possibility of avoiding surgery becoming is more and more realistic for some patients who achieve a complete response to the neoadjuvant therapy. That practice is also coming up. That is, a breast cancer patient can avoid surgery. Yeah, it may come up in the future. And another thing is the less invasive strategies. That is, we can try for image guided ablation or the procedures like the vacuum assisted actually resection. It's actually a less invasive procedure. It may replace the traditional surgery in some cases, not for all cases, but some cases in the future. Then another area of advancement that happened is the reconstruction. That is, in those patients who do have surgery, the innovative reconstructive techniques like the 3D nipple tattooing are improving the cosmetic outcome of the patient. So these all are the surgical advances that is happening. So as I mentioned in the earlier part of my talk, the use of AA is coming, or artificial intelligence is coming in a big way in the breast cancer treatment also. It can detect tumors more accurately at an earlier stage. It helps the clinician to predict the treatment response and also to calculate the recurrence risk. So whether there is increased chance of the cancer coming back or not. And also it supports smarter, faster the medical decisions. So this is about the role of artificial intelligence in breast cancer treatment. So what is the future? A future full of hope towards a world where breast cancer is fully curable, and each discovery in the field of breast cancer, it brings us closer to prevention and cure. Hope, research, and unity light the path ahead. So this is about actually Russia's cancer vaccine. So I have just included this only for the sake of discussion. It is still in the infancy stage. Actually, they have tried only in animals, that is in the rats. The human experiment is still not started. It may take the years to know whether it is useful for humans or not. That's all. Actually, early detection saves lives, and also research changes the future. Thank you. I think we can
Absolutely
discuss
good.
more about.
Yeah.
Yeah. Yes, sir.
Absolutely good, Varun, taking through the future directions of breast cancer management. You are taking the breast cancer treatment away from the surgeons. So that may be a good change. Shall I ask you one just question for your triple negative patients? Your other than the targeted therapy for immunotherapy, you do the BRCA testing. Apart from that, do you do this PDL1 for the Pembro?
Yes, sir. Yes, sir. You actually.
What
we
are
doing that.
the IHCs which help you for your immunotherapies, like other than the BRCA1?
Therapy, mainly we are looking into the PDL1, but in some cases we
Yeah.
look into the NGS also for seeing the TMB and all. Tumor mutation delta.
Yes. Okay. And what is the response like for your with the Pembro on a triple negative? But
Still it is not so great, sir.
in metastatic setting or
in metastatic setting.
right. Metastatic setting, many drugs are now available actually.
Yes.
Previously,
But now,
when a patient,
actually, yes, sir.
when a patient comes with the metastatic breast cancer, we call it a day. We don't have much to offer. Now we have many
now
in our
immunotherapy, antibody drug conjugates are there.
Yeah.
And in the future, CAR-T cell therapy also will come for breast cancer.
And any experience with your this circulating tumor cells?
Not in breast cancer. I
Yeah.
have used that in stomach cancer and colon cancer.
No, breast
not
cancer.
in breast cancer.
And this is open for discussion. Actually, the audience can also ask questions if it is. And if there are no questions, Dimple, what is the next procedure like?
Wonderful. Okay, shall we conclude, sir?
Yes. We can conclude.
Yeah.
I think there are good discussions were there, and a lot of new doubts have been cleared. So now then there are no more questions. We can conclude. That means.
Thank you all. We have come to the end of today's webinar. ഇന്നത്തെ ഈ വെബിനാറിൽ പങ്കെടുത്ത എല്ലാവർക്കും നന്ദി അറിയിക്കുന്നു. പ്രത്യേകിച്ച് നമ്മുടെ ക്ഷണം സ്വീകരിച്ച് ഈ പങ്കെടുത്ത ശ്രീ സാബു ചെറിയൻ, മിസ് എസ്തർ അനിൽ, അതുപോലെ നമുക്ക് വിലപ്പെട്ട അറിവുകൾ നൽകിയ നമ്മുടെ ഡോക്ടേഴ്സ്, ഡോക്ടർ വരുൺ, ഡോക്ടർ ജാനകി ആൻഡ് ഡോക്ടർ ജയകുമാർ. ഒരിക്കൽ കൂടി നന്ദി പറഞ്ഞുകൊണ്ട് നാളെ ഇതേ സമയം കാണാം. എല്ലാവർക്കും ശുഭരാത്രി. ഗുഡ് നൈറ്റ്. താങ്ക് യു വെരി മച്ച്.